Good afternoon, and thank you for the opportunity to present the results of the REGAIN trial. It's a great pleasure to present to delegates in Boston. My name is Gordon McGregor. I'm a clinical academic professor in clinical exercise physiology and rehabilitation at University Hospital Coventry in the UK National Health Service, and also at Coventry University in the UK. The REGAIN trial was led by University Hospitals Coventry and the University of Warwick Clinical Trials Unit, and was funded by the National Institute for Health and Care Research, NIHR, equivalent to the NIH in the US. Quick disclosure before I continue. So I received payment as a director of a company called Atrium Health in Coventry, and this is a not-for-profit social enterprise that delivers rehab services for the NHS, for academia, and for the local community. And Atrium Health provided the practitioners who delivered the intervention for the REGAIN trial. So the rationale for the REGAIN trial was that it was funded in summer 2020, and at that point, post-COVID-19 condition hadn't yet been recognised. We'd seen a long-term post-viral condition previously in other epidemics such as SARS, so we expected that something similar would develop with COVID-19. We also knew that centre-based rehabilitation programmes could help people with similar symptom profiles, perhaps people with lung diseases and cancer. And we also knew that centre-based programmes wouldn't have the capacity to accommodate the vast numbers of people that were expected to develop post-COVID-19 condition. So we developed a virtual online programme to be delivered live in group sessions. We enrolled adults who were discharged from hospital at least 3 months earlier after COVID-19 infection. So everybody on the trial had been in hospital with COVID-19. Anyone who had substantial lasting physical and or mental health problems that they attributed to COVID-19 was eligible to join the trial. We recruited 585 adults with a mean age of 56 years of age, slightly more women than men, and on average, the time since hospital admission was around about 323 days, so nearly a year. Important to note at this point that we did not exclude people at enrolment if they had symptoms consistent with post-exertional symptom exacerbation. Participants were recruited across England and Wales by mail-out from 22 hospitals, and also by an NHS digital DigiTrials national mail-out. This is a system whereby we were able to search hospital discharge records on a central UK database, identify people who had been discharged from hospital with COVID-19 more than 3 months previously, who may be eligible for the trial. We sent out all in all 40,000 invites, as only 1 in 10 at the time were estimated to have post-COVID-19 condition based on our definition of lasting physical or mental health problems beyond 3 months post-discharge. 585 adults were randomised to either usual care or REGAIN, and we had an 80% follow-up rate at 3 and 12 months. So 485 people provided follow-up data. Usual care was a single 30-minute one-to-one online session of advice and support, and the REGAIN intervention was delivered online via Zoom from a single trial hub, and that included a one-to-one consultation followed by weekly home-based, supervised exercise and psychological support sessions. These were delivered in groups, in live sessions online over 8 weeks by clinical exercise physiologists and physiotherapists, and supported by health psychologists. The REGAIN programme itself was co-developed very early in the pandemic by people who had been in hospital with COVID-19 and were experiencing the lasting effects. And this group was supported by clinicians, academics, and stakeholders. The group support sessions in the REGAIN intervention were semi-structured and minimally facilitated, and they were supported by a comprehensive workbook. Each session did have an overarching theme, for example, sleep, fear of activity, pacing, so stop, rest, pace, managing stress, anxiety, and so on. And these sessions gave the people the opportunity to share their experiences with others, and were designed to improve adherence to the intervention and to help manage symptoms, improve functioning, and reduce the distress associated with a severe chronic illness. The group exercise sessions involved equipment-free bodyweight exercise to help with muscle strength and endurance, cardiovascular fitness, but equally coordination, balance, and most importantly, probably confidence in taking part in physical exertion. Our exercise was highly individualized and personalized and did not take the approach of graded exercise training that has been used previously. The primary outcome was health-related quality of life measured with the proper score. And this is done by questionnaire, which was filled in by participants online and delivered centrally to our database anonymously. Proper is a part of the PROMIS suite of measures from the National Institute of Health in the US. It's a preference-based utility measure and it's calculated from 7 subscores. I'll show you more detail on the next slide. A clinically meaningful difference in the proper score hasn't formally been confirmed in post-COVID-19 condition, but literature suggests it's somewhere in the region of 0.03 to 0.05. And this is similar to other utility measures such as the EQ5D, which you may be familiar with. The clinically meaningful difference in the proper score is still work in progress. There are still studies underway by the NIH to establish exactly what clinically meaningful difference is for this measure. The main findings: the REGAIN program led to improvements in health-related quality of life at 3 months, and importantly, sustained improvement in quality of life at 12 months compared to the usual care group. You can see in the figure that both groups improved over time from baseline, but the REGAIN intervention group improved significantly more at each time point where we measured data, so 3, 6, and 12 months. The difference at 3 and 12 months was statistically significant, and there was a 0.03 difference between groups. So this might seem small, 0.03, but as I said, this is clinically meaningful. It's within the clinically meaningful range for the proper score as we understand it at this moment in time. And the effect may be modest. It's at the lower end of the meaningfulness level, but taking our findings overall, we can demonstrate statistically significant clinical benefits. And this treatment had few observed harms, and the magnitude of difference for individual patients might find attractive. And also, to the best of our knowledge, there are no other treatments of proven effectiveness for this condition. Interestingly, the size of the difference at 6 months was the same as it was at 3 and 12 months, so 0.03, the difference between the groups. But this didn't quite reach statistical significance, which is probably due to a statistical anomaly. The important thing is that the trajectory of improvement continued from baseline to 12 months. So the difference in the improvement between the intervention group and the usual care group was sustained at 12 months. To give a bit of context to these results as well, and to help patients decide whether or not they feel that this is an intervention that they would commit themselves to, we also calculated numbers needed to treat. So in order to feel at least somewhat better now, so that was including people who felt somewhat better, much better, and significantly better, we had a numbers needed to treat of 5.4. So essentially, for every 5 people treated, 1 of them felt at least somewhat better now. The proper score is comprised of 7 subscores: depression, fatigue, sleep, pain, physical function, social roles, cognitive function. You can see additional subscales and secondary outcomes on here, but we're going to focus primarily on the subscores. In these forest plots, you can see that everything to the right of the line means that the subscore was affected more favourably by the REGAIN intervention compared to usual care. Everything on the right-hand side of the line contributes to the difference in overall quality of life that we saw between the groups. So the overall quality of life score is calculated from these 7 subscales. The plot on the left-hand side is 3 months, and the plot on the right-hand side is 12 months. Looking at 3 months, you can see that 6 of the 7 subscores were affected more favourably by the REGAIN intervention. Of particular relevance, we noticed that depression, fatigue, and pain interference were statistically significant and clinically meaningful, indicating that the improvement in overall quality of life was driven predominantly by these 3 variables. So depression, fatigue, and pain interference, all of which are very important in post-COVID-19 conditions. At 12 months, all of the subscores were affected more favourably by the REGAIN intervention, and depression, fatigue, and sleep were of particular importance. The fatigue findings are particularly interesting, given that fatigue is one of the most prevalent and debilitating symptoms associated with post-COVID-19 condition. As with other post-viral or autoimmune conditions, fatigue is pervasive, enduring, and often treatment resistant. So to be able to show an effect in fatigue with the Regain intervention was very interesting. A little bit more about the population that was studied in the group. 11% were of non-white ethnicity, so perhaps lower than we would have hoped for. We would have hoped for about 20% contribution in our data pool from groups from minority ethnic groups in the UK. Traditionally, this is an issue in clinical trials, and 11% was a reasonable outcome. 34% of the population were treated in hospital, in ITU or HDU, so that's intensive therapy unit or high dependency unit. But important to note that only less than 10% of these people were mechanically ventilated. So they were ill enough to be in hospital, but not unwell enough to be mechanically ventilated. 40% of the case level had case level on at least one measure of mental health, so whether it be PTSD, anxiety, or depression. And nearly 40% were unable to work due to COVID-19 sequelae. Safety was really important. The programme was very well tolerated and safe. We ran 33 intervention groups, which contributed to over 1,000 hours of live exercise and support sessions. Only one serious adverse event was possibly related, so not definitely, possibly related to the live exercise session. We did have a patient who had syncope and vomiting 24 hours post-exercise session, which may have been as a result of having exercised the day prior. But with very close monitoring, we didn't identify any instances of post-exertional symptom exacerbation, and we monitored for this before and after every single session that was completed. Always important to look at adherence in a complex intervention such as this, a lifestyle intervention or a rehabilitation intervention. So we did a case analysis, complies average causal effects analysis, and for that we took full adherence to be equivalent to attendance at the one-to-one consultation session at the start of the programme, at least 5 of 8 live exercise sessions, and at least 4 of 6 live support sessions. Nearly 50% of participants in the intervention group fully adhered with the intervention according to our criteria, which is actually quite impressive. And a further 40% partially adhered. The adherence analysis was important. So by adhering fully, the effect of the Regain programme on overall quality of life, so the proper score, was double. So we noticed a difference between the groups of 0.05 at 3 months and 0.06 at 12 months, whereas it had been 0.03 in the full intention to treat analysis. Probably worth noting as well that, to give a bit of context, that our control group, our usual care group, received probably more intervention than might have been offered in clinical practice, which in fact may have masked the true effect of the Regain intervention. Nevertheless, we saw a highly clinically meaningful and statistically significant difference between the groups in overall quality of life at 3 and 12 months. We collected a range of data for secondary outcomes, and in terms of the intervention versus the usual care, 50% of people in the intervention group felt at least somewhat better at 3 months compared to 30% in the usual care group. The severity of PTSD was much reduced at 3 months and 12 months in the intervention group to a clinically meaningful value. Physical activity participation was greater at 3 months in the intervention group, but interestingly not at 12 months. The groups were equally physically active at 12 months. We also conducted a comprehensive process evaluation that involved a large number of qualitative interviews. So 40 participants were interviewed and 5 practitioners were interviewed. And this confirmed really high levels of acceptability from participants and practitioners. Participants discussed that the sessions were very highly valued, and probably the most important thing that they took from it was that being listened to was really important. So being listened to by somebody who knew what they were going through, so participants, but equally a practitioner who had experience of working with people with post-COVID-19 condition. We also did a thorough health economic analysis, which supported the clinical findings. We noticed that there was a high probability that the Regain intervention was cost effective in the UK NHS. So just to conclude with the key messages from the trial, group rehabilitation delivered online improves health-related quality of life for people with post-COVID-19 condition who've been in hospital at 3 months and 12 months. Regain is the first and still the only high-quality RCT that confirms the benefit and, importantly, the lack of harm in this patient group of a rehabilitation intervention. Regain is not a panacea. It is most definitely adjuvant to medical care. People obviously need input from a range of specialties, medical specialties, including rehabilitation practitioners. But we do believe that findings should assist clinicians with implementing treatment strategies in this post-COVID-19 population. Really importantly, Regain is an accessible, resource-efficient program because it's delivered online from a central trial hub, and it has great potential to be delivered at scale. And just to finish, the Regain intervention was highly effective in a post-hospitalisation group of people with COVID-19. We don't know, we can't extrapolate these results to people who weren't hospitalised with COVID-19, but there may be elements of the programme that would support ongoing recovery in people who weren't hospitalised with COVID-19. Future research would be needed to identify and confirm this. Thank you for listening.